Hello, and thank you for joining me on Everyday Medicine. I'm Dr. Luke, and in this podcast series, we'll be sharing conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas, and advice, which I hope will be applicable for our medical practices. In the previous podcast, we discussed pharmacological therapy as applied to obesity with Dr. Matthew Peverelle. And today, we'll be discussing endobariatrics with Dr. Matthew Peverelle also. Well, for Australian audiences, listening does give us eligibility for our CPD, so log in, add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. So in the preceding episode with Dr. Peverelle, we reviewed pharmacological approaches to obesity management. In this episode, we'll review an alternative approach to bariatric surgery referred to as endobariatrics. These are endoscopic interventions sitting between lifestyle, pharmacotherapy and bariatric surgery, and they're suited for patients with BMIs between 30 to 40 kilograms per metre squared who don't want surgery or who aren't surgical candidates. The main interventions include 1. Intragastric balloons, which are temporary devices associated with 10 to 15% weight loss. 2. Endoscopic sleeve gastroplasty, which reduces the gastric volume with a 15 to 20% efficacy. Is currently the preferred endobariatric technique. Third is duodenal mucosal resurfacing and duodenal jejunal bypass liners. Well, to discuss these options with us in more detail, please welcome back Dr. Matthew Peverelle. Matthew is a gastroenterologist who completed his advanced training in gastroenterology at Monash Health and Austin Health, including working at the Victorian Liver Transplant Unit. He went on to complete a hepatology fellowship at the prestigious King's College Hospital in London, has developed a strong interest in both hepatology, luminal gastroenterology, and endobariatrics. Thank you for joining us as he brings his expertise to the podcast. Matthew, welcome back to Everyday Medicine. We're on to a part B of our weight loss journey with you, and thank you for the discussions.
No, that's okay. I'm able to clear my throat. I got something stuck in my throat, so I have to
you might need a gastroscopy. But thank you for taking us through, that very erudite discussion on the pharmacological approach to weight loss.
Yeah, of course.
Now, we know a lot about bariatric surgery. Initially, we had profusion of people coming for lap band surgery. Now we're talking about gastric sleeves and bypass, and there's the omega bypass, which is favoured by surgeons. But there's a different approach altogether that you'd like to talk about, which is the endobariatric approach. And I don't think people are really aware of the value that perhaps you can offer here and what's available. Can you talk to us a little bit about this? You become interested in working, studying away, improving your skill level. Tell us a little bit about what it is and what it can offer people.
Yeah, of course. So there are a lot of people who don't want a surgical solution to their obesity, and a lot of people who don't want to take a medication for the rest of their life for their obesity. And that's kind of where endobariatrics fits in. So endobariatrics is essentially just an endoscopic, so camera-based in the mouth going into the stomach, endoscopic-based weight loss procedures. And there's a pretty simple dichotomy that I have in my head. One of which is intragastric balloons, which are inserted through the mouth. A deflated balloon is inflated through the mouth into the stomach and then inflated to a certain volume. And that induces weight loss through both the volume effect and delayed gastric emptying. And then aside from the intragastric balloons, you have a relatively novel endoscopic technique called the endoscopic sleeve gastroplasty. It's been around maybe about 15 years now, first started in the United States. And it is essentially the endoscopic version of lap sleeve. So if someone says they've had a gastric sleeve, that refers to having had a surgery where the surgeon will divide the stomach and create a smaller remnant stomach surgically. The endoscopic sleeve gastroplasty, or ESG for short, it's done via a gastroscope, so the camera goes in the mouth into the stomach. There is then a device that is fitted to the endoscope, which allows the gastroenterologist to take full thickness needle suturing bites of the stomach. It's done under general anesthetic, so patients are asleep for the procedure. And in that way, they are able to essentially draw the walls of the stomach in closer together without any cuts, but utilizing sutures that are done internally. And it effectively accomplishes a similar remnant stomach volume. You lose about 70% percent of your stomach volume as a result of the ESG. There have been some trials. The biggest one is the Merit trial published in The Lancet a few years ago, which showed quite a large amount of durable weight loss with the ESG procedure. So yeah, in short, that's kind of what my areas of interest have been. And I think it's not a very well-known area of bariatrics and weight loss medicine.
Well, tell us, how would you decide whether you were going to put a balloon in or whether you were going to do an ESG in terms of your advice to the patient?
Yeah.
This is, let's say it's a patient you've already considered a pharmacological therapy, perhaps you're already on that, is that be true? And then you're going to progress on, or how do you weave it into the pharmacological therapy that we've been discussing?
Yeah, these procedures can be paired with pharmacological therapy, although around the timing of the actual procedure, the pharmacotherapy such as Ozempic or Wegovy would need to just be withheld. In terms of choosing the right option for the patient, so probably one of the biggest ones is cost. The cost of intragastric balloon is less than the cost of an endoscopic sleeve gastroplasty. The other factors that I would consider would be, does the patient want a temporary reversible option that can be removed after anywhere between 6 to 12 months? In which case I would...
Yep.
The balloon, yep. Or I'd ask them if they wanted to do the ballooning rather than the ESG. If they wanted something that was more durable and a bit more permanent, then the ESG would be the more suitable option. A lot of patients, they want a temporary solution that allows them to lose weight, but also get their house in order, so to speak, where they can really try to do the lifestyle things that we've spoken about, see a dietitian, improve the composition of their diet, get some exercise on board. And in the meantime, that intragastric balloon allows them to lose a substantial amount of weight, which provides a bit of a positive feedback, motivating loop for them.
Tell us about that, the sort of percent weight loss we could expect with a balloon versus the endoscopic gastroplasty.
Yeah. So there are a few different kinds of balloons in the market. There's 3. There's the Allurian, which it's actually one that you can swallow and then it inflates within the stomach. That one stays in place for about 3 to 4 months before it self-deflates and then it passes out through the gastrointestinal tract. That one, because of virtue of the fact that it is not adjustable and is in for the shortest length of time, accomplishes around 10% body weight loss. But there is a substantial amount of people who will not lose much weight at all with the Allurian. The other 2 balloon options, one is the Orbira, which is a 6-month balloon. And then the one that I prefer the most, which is the SPATS 3 balloon, which is a 12-month balloon. And the reason I prefer the SPATS 3 is it has an adjustability component to it. So the balloon can be inflated on the day of the procedure to a certain volume, let's say 500 mils. Patient then engages in a weight loss program with a dietitian, exercise physiologist, bariatric physician. Most of the weight loss will occur in the first 3 to 4 months, but then you can start to see the weight loss plateau. And that's where the SPATS 3 has the added advantage of the adjustability, because you can then repeat the procedure at, the 4, 5, 6 month mark or what have you, and increase the volume of fluid that is in the balloon and kickstart the rest of the weight loss out to the 12-month mark. The balloon then does need to come out after 12 months. It's only licensed to be in there for 12 months. But I've had some patients who they've been that pleased with their results that they've then requested to have another balloon put in soon after. That is certainly an option.
What side effects can the patients expect, and practitioners who are dealing with patients that you've helped? What sort of side effects are we going to have to think about?
Good question. So most patients will get some side effects in the first couple of days after the balloon is inserted, and that's just the stomach is accommodating the balloon. It is getting used to the balloon. It senses that there's a foreign body in the stomach and it's trying to digest the balloon basically. So cramping is quite common afterwards. Nausea is also common, and pain to a lesser extent, but it's mainly cramping and nausea that people get. And so I tend to manage that with antispasmodic agents like baclofen and buscopan. And then for the nausea, we usually give quite a potent anti-nausea agent on the day of the procedure, like Akynzeo, which is a aprepitant. And then in the post-procedural period, the patient goes home with some other anti-nausea medications. It can be quite varied how people go afterwards. Usually by about day 5, we should say that we tell patients that they really shouldn't be having any more residual symptoms. The stomach should have gotten used to the balloon by then. And so symptoms after the day 5 mark warrants further evaluation.
So maybe a rough 5 days, and then generally tends to settle.
Rough 5 days.
You do this as an outpatient general, or would you admit them overnight? Generally, it's an outpatient day procedure.
The procedure is it's quite simple. It's almost just like a gastroscopy with an extra 5 minutes balloon insertion. So it's a day procedure. The patient is just given a bit of sedation to insert the balloon. They go home shortly afterwards.
Yep. Okay. So that's the balloon. Remove it after perhaps 6 months or maybe 12 months if it's a SPAT3.
Yep.
We've got the nausea early. Weight loss maybe 10 to 15%. That sort of amount. Hopefully some lifestyle changes or a little bit more with the SPATs.
Yeah, with the SPATs, I usually quote around 15 to 20%.
15 to 20.
That's the median. People exist on kind of either ends of that bell curve, obviously. You've seen people will lose upwards of 30% body weight loss. Most people, about 90% of people will lose at least 10% of body weight loss with body weight with the SPAT3.
So, okay. So that's quite an impressive percentage, really. Tell us now about the endoscopic sleeve gastroplasty. It does sound like quite a complicated procedure, and I can imagine there could be bleeding and other complications. What sort of difficulties do you experience with it?
To be honest, the actual full thickness suturing of the stomach internally is not that difficult. What is difficult is it can be quite a lot of troubleshooting things that come up with whether the sutures are placed in the right position or, I don't want to say tangled, but you've got a lot of suture there in front of you. You can form little loops and things like that. So the technicalities of using the overstitch device, the suturing device to perform the ESG can be quite challenging, but the actual suturing of the stomach itself and drawing the walls of the stomach in, it's not overly challenging once you've got some experience under the belt. You mentioned bleeding, and certainly to anyone who is probably listening to this and thinking they're suturing the stomach internally with needles, how is there not just blood everywhere, and how is the patient not, dying on the table? One, the clotting system kicks in, so blood usually stops just through that mechanism. Two, by drawing the walls of the stomach in and by suturing the folds of the stomach in tight, that creates a tamponading effect, which further encourages the bleeding to stop. Hemostasis, exactly. You can get a little bit of bleeding happening, but it usually stops by itself and doesn't need to be managed in any other way other than just completing the ESG, which should stop the bleeding just through the tamponading and natural coagulation of the body.
You're going to keep these patients in for 36 hours, 48 hours after the procedure?
No, they go home the same day.
Really?
So that's one of the benefits.
You're a magician.
No,
Same day.
I didn't come up with this. I didn't come up with this technique, and I'm by no means the pioneer. That's one of the big advantages of this procedure is that it doesn't require a hospital stay. Patients come in and go home on the same day. The risk of major complications is less than surgical version of this, and most of the complications can be managed conservatively without needing any further procedures.
Give us a quick rundown. Major complications. What are we going to see?
So major complications. So the overall risk of any major complication is less than 1%, comparatively to bariatric surgery, which is around 3%. Major complications in the case of the endoscopic sleeve gastroplasty would be bleeding, gastrointestinal bleeding, which would require a repeat gastroscopy to localize and stem the source of bleeding. There is a small chance of a perigastric collection forming, a collection of fluid on the outside of the stomach. That can be managed conservatively. If there's any concern for infection of the collection, then oral antibiotics plus or minus ultrasound-guided drainage of the collection.
Yes. Okay.
But less than 1% in total for any major complications such as those.
And what sort of weight loss are we going to see with the gastroplasty?
So the techniques for the ESG have evolved over time. And so now we are utilizing different suture patterns compared to what was done when this technique first came onto the market. And so by using these new suture patterns, we get much greater reinforcement of the stomach in a smaller remnant volume. And we think we are affecting delayed gastric emptying more than what we were. So as a rough idea, about 22% total body weight loss at 12 months. And there's been some longitudinal data out now to 5 years and 10 years showing that weight loss is relatively durable out to 10 years. At the 10-year mark, people can expect to have roughly maintained somewhere between 10 to 15% of their body weight loss, which if you compare that to surgical technique is relatively similar.
After the balloon is removed or after the gastroplasty, are you going to continue any pharmacological therapy with these patients or generally not?
It's up to the individual patient and what their post-procedural course is like. If I'm concerned that they've become sarcopenic that they've lost a fair bit of muscle, that they're not maintaining their protein intake for their needs, then I would not encourage them to go down the pharmacology route until we had gotten those things in order. But these procedures can certainly be combined with pharmacological therapy for the right patient.
Well, Matthew, thank you very much for taking us through. That's tremendous. There's one other question perhaps I will ask you, and this is more a theoretical idea, that ghrelins in the fundus, I believe it's released from cells in the fundus.
Yes.
Are you aware of any attempts to do an ESD in that area, or to APC the area, or to try and ablate the mucosa there, induce a degree of atrophy somehow, thermal means or otherwise, to take away that greed hormone, the ghrelin? Are you aware of anyone trying that? Because there's some removal of that tissue with the sleeve gastrectomy. I don't know how exactly the gastroplasty affects that, but yeah, any thoughts or comments on that?
I'm very impressed that you seem to know a lot about a lot. There is some research being done into fundal ablation using APC, so ablating the fundus of the stomach where those hormones are
thought to be
created. And thereby inducing weight loss. There's also some research looking at duodenal ablation as well as a treatment for type 2 diabetes to reduce glucose absorption.
Capacity
that are currently undergoing.
Yeah, it's a fascinating field, isn't it, Matthew? I mean, you've demonstrated your skills and ability here, running through all the pharmacological options in our first discussion, and now this is very interesting. The endobariatrics, a bit more complex. It's great that we've got you doing this here in Melbourne and offering the service. So I wish you well, and thank you so much for your expertise and time taking us through this, Matthew.
Yep, happy to do this again. Thank you.
All the best. Thank you. I'd like to thank you all for joining me in this podcast episode with Dr. Matthew Peverelle. It really complements the pharmacological therapy podcast we held with him, and I think draws to our attention some new techniques that are being applied to weight loss. During the podcast series, we'll be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but as general information only, and they do reflect the opinions of the guests interviewed. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed and may be emailed to manager@gihealth.com.au. Thank you.